Okay, thank you. We are back. This is Senate Health and Welfare. We're continuing our work now on S-109. That's the act relating to Medicaid coverage for doula services. And as we indicated earlier, we do not have Ledge Counsel with us this morning, but we do have some witnesses to provide information about the bill. And we're starting out with Rebecca Copan.
Right.
And listen, I know that there are others who are here or are listening who would like to testify and help us to the bill. So please get your information to your representative and then to Kiki, please. That'd be helpful. Thank you.
Good morning. Rebecca Copan, Blue Cross Blue Shield of Vermont. I just want to thank you for having this conversation today. And I want to say that Blue Cross is agnostic on S-109. And I think it's a policy decision between DEVA and the legislature. And we're just here to talk about, I'm just here to talk about the Royal We, the Blue Cross Vermont experience. This bill, I do believe, has a lot in common with the freestanding birth center bill, which just want to make a pitch that you consider that as well. So we think a lot about health equity at Blue Cross, and I do in my daily life. We are the second whitest state in the nation. And all too often people look at the demographics and say that because the numbers are so small, it's not a problem that we have here. You know, having the racism, the unconscious bias that a lot of bigger cities and states have, when in fact it's really the opposite. Yesterday, the Green Mountain Care Board was listening to a report out of the Act 167 community engagement process. And a quote that really hit me like in the gut was a hospital executive that said, we don't have any diversity in Vermont, so it's not a problem here. And I think a key task in a very homogenous state is challenging what lies beneath our assumptions, our stereotypes, and looking at our unconscious biases in the eye. It's really uncomfortable and it's really critical, especially given the very small number of people of color, and for whom the people who have English is their second language. Especially in healthcare, when people are trusting us with their most vulnerable places, often in life and death situations. So I want to throw out some maternal health data that I think is pretty shocking. It's really shocking to me.
Do we have this in?
I was going to bring slides, but I'm technologically illiterate, so I'll send it to you.
Perfect.
I figured I would.
Okay, that's fine. I just want to know how busy we have to be writing.
No, I'll send it to you.
Yeah. Okay. Good.
So 1 in 5 women report mistreatment from medical staff during pregnancy, according to the Centers for Disease Control, the CDC. The women reported signs of mistreatment, such as being verbally abused, having their requests for help go unanswered, having their physical privacy infringed upon, and receiving threats to withhold care. About 2,400 women were surveyed, and it crosses the gamut as far as population. 20% who said they were mistreated, 30% were Black, 29% were Hispanic, 27% were multiracial, 19% were white, and 18% were American Indian, Native Hawaiian, Pacific Islander, and 15% were Asian. So of that 20%, it really crosses the spectrum of the population. It's everyone. 45% of respondents say they were hesitant to approach their provider with questions or concerns during their maternity care. They cited reasons such as thinking that what they were concerned with was normal, not wanting to be seen as difficult, making a big deal out of something, or being embarrassed, or thinking that their provider's in a hurry. Just imagine if those people had a trusted person in their corner during that pregnancy, labor, delivery. When I think about the birth of my children, my husband is a wonderful, supportive person. He is very kind and he also does not want to be seen as, getting in the way. And sometimes you need someone to be your advocate, and make sure that your voice is being heard in the process. An NPR story found that in 2021, 1,200 people died from maternal-related causes, a 40% spike from the previous year. So the pandemic made it significantly worse. The US is the most dangerous developed country to give birth in. If we look at the statistics, this one really sticks with me. Black birthing people in the United States die at rates similar to those of women in Mexico and Uzbekistan. Just want to sit with that for a minute. It is dangerous to be a Black person giving birth in this country. Black people are 3 times more likely to die from childbirth than just complications than white women, and face a 70% higher risk of severe maternal morbidity or life-threatening events than any other racial group. And it's often related to conditions that require attention throughout the pregnancy. So Black women are 3 times more likely to die in pregnancy than white people. And these rates increased precipitously with maternal age. And I can send you all the data, it's really shocking. So what's really kind of alarming about these statistics, that according to the CDC, is that 60% of these deaths are preventable. A key point about this is that these disparities span education levels, socioeconomic status, age, geography. It points to a deeper seated issue like underlying chronic conditions, racial inequities, and bias within the healthcare system that has to be addressed systemically and across the women's lifespan, not just during pregnancy. So this is very depressing. So what can we do about it? We can take meaningful actions to combat the cultural, operational, and structural barriers that have created these inequities. Maternal healthcare has to be culturally competent and culturally conscious. Implicit bias trainings have to be taken into account, and we need to create better trust in patient-provider relationships. So, coming back to this bill, doula care seems really simple. A lot of people say, "What is a doula?" It's a funny word, which I think can often be a barrier in itself. It's really low tech. It's a very low tech intervention. And you may wonder what it has to do with these statistics. But research has shown that the presence of a doula, just a trusted person in their corner, in pregnancy, labor, delivery, and postpartum, is a simple but effective key to closing the gap on maternal health equity. They've been shown to significantly improve outcomes like reducing cesarean births and preterm deliveries. So I work for a health plan, Blue Cross Blue Shield. We are a single state plan. We support a tiny population. And so when we think about considering a new benefit, cost is front and center. We need to think about what's the return on investment, essentially. So how does it hit our numbers in the pocketbook? So I just want to look at the numbers. The cost of a normal birth can range from $9,300 in Morrisville to just under $29,000 in Burlington. A cesarean birth can cost, same hospitals, $20,000 at Copley, or about $35,000 at UVM. The cost for a premature birth can cost $61,000. And that just scratches the surface for like the ongoing NICU stay and the impacts of that baby over their life. So the cost differential between a normal healthy birth at term and a birth with complications is significant. Doulas can also reduce anxiety and depression, which can directly affect labor progress and improve normal birthing rates, as well as reducing disparities by advocating, educating, and supporting the birthing person of color to be engaged with their own healthcare and to be heard and respected by their providers. When a birthing person has a trusted person in their corner to advocate for them, it makes an enormous difference in their health outcomes. So postpartum, doulas have also been shown to increase breastfeeding rates, which have lifelong implications for the baby, and lower rates of postpartum depression, which is a significant problem, especially in a dark, wintry state like ours. There was an incredible retrospective cohort study using Medicaid medical claims from California, Florida, and a northeastern state, which they don't mention which one, that compares maternal health outcomes between people who did and did not receive doula care between 2014 and 2020. The study found that women who received doula care had a 52.9% lower odds of a cesarean delivery. That's a big number. And they have a 57.5% lower odds of postpartum depression and postpartum anxiety. Doulas who provide care with a clinical team that includes a midwife most consistently showed a reduction in the odds of cesarean, which brings into that pitch for considering the freestanding birth centers. And it's regardless of when the doula intervenes in which trimester. Women who received doulas showed a 64% reduction in the odds of postpartum depression and anxiety. So Blue Cross is a health plan. I have to tell you, this is a passion project of mine. The Blue Cross Association mentioned doulas as a part of their bigger health equity strategy, maybe about 2.5 years ago, and I grabbed it and I have marched it along with. We have a small but mighty team, a health equity team, our diversity, equity, inclusion team, and our Better Beginnings, which is our maternal health, wonderful maternal health team. And we approached our innovation lab and said, let's try a pilot. Just try it out. Let's see what it looks like. Let's see what our data shows. So we're in the middle of it now. It's specifically a health equity pilot focused on 30 slots. It's focused on people, there's Black, Asian, Pacific Islander, Hispanic, or refugees, have 20 spaces. And there are 10 spots for white people with a high resource utilization band score. So people that had trouble with a birth before, someone who's socially isolated during pregnancy, if they had a previous traumatic birth. As of right now, 4 have given birth. And I won't go into the quotes of what they said their impact was, but it was an enormous help in their birth. So I just want to end by saying this is a really important issue. We have a great opportunity to support people more in their maternal health journey. This is a low cost for a high return, and I just want to also invite you to have a conversation with the Vermont Department of Health. They joined us in applying for a HRSA stamp grant, the Human Resources, I can never remember, Health Resources and Services Administration's federal grant that would support maternal health equity efforts in the state. So thank you. I really appreciate your time and your focus on this.
Oh, thank you. We've done an exceptional amount of research, and we will have the DOH in as we take more testimony on the bill. I do have a couple of questions, if you don't mind, and when you send your amazing amount of research in, we'll be able to see if the answers are there. One is, which probably asked the doulas this question, but the follow-ups support services after birth, how does that happen?
I think you have doulas.
We'll let our doula answer that question. And then how does Blue Cross and Blue Shield cover, if at all, the doula services at this time? So
our pilot covers, it's tricky because.
So it's through the pilot?
This is a pilot.
Okay.
We're about halfway through it. There's, we have 8 spaces remaining for people of color. If you have people in your districts that are Blue Cross members, we would love to support them.
They have to be pregnant, I'm assuming.
They have to be pregnant. Oh, God. And through the Better Beginnings program, which is our maternal health program, because of the certification is complicated, and I'm sure the
that's a question. That's my next question. But if you have information, fine. Otherwise, we'll wait to see.
There's a bunch of different certifications, and we did not want to say you have to do this particular one.
Yeah.
So we are leaving it to the person to choose who works best for them, and we fund it similar to our car seat program. So we offer a reimbursement for a car seat up to, I want to say $125 for the car seat. The doula is similar, where they get $1,000. They just submit their receipts, and we give them the reimbursement.
That's within the pilot program?
That's the pilot.
Yeah, okay.
I have to say, it only gives part of the amount. You know, it's more expensive than that. And I think as I'm looking at who is enrolling in the pilot, I think cost continues to be a barrier. And so I think that's something to consider. I would look at your numbers in the bill. It seemed really low.
Yeah.
So
That's what we've heard.
It's already a little.
Wait,
the
okay, is
reimbursement
this a
numbers.
follow-up because Senator has got a waiting?
No, go ahead.
Okay.
The reimbursement numbers in the bill, I think it was like 600.
850.
Yeah.
Yeah, I thought they were low too. Are you done? Okay.
Go ahead.
So just to follow up on what Senator Lyons asked you about what you all cover, so the bill itself is focused on Medicaid
Yes.
program. And I know you said that Blue Cross is staying agnostic or neutral or whatever. But, you know, there is another route that we could go that would require it as part of our base health plan or whatever it's called, that then would require our private insurers in the state to cover doula services. And you might not be prepared to answer that, but is that something that Blue Cross Blue Shield would support?
So because it would increase the essential health benefits, it would be
That's the word.
it would be a state defrayal. And Nolan, I think, could answer that question of what it would cost the state to for the state defrayal.
Mhm.
We have a preliminary something on that.
We, Blue Cross numbers, the royal we again, have about 1,000 births a year.
Mhm.
The people who would use a doula, obviously is not that whole population. So it's a question of, you know, how much it would cost. And, you know, I'm working, as soon as this pilot ends, we're bringing the data to.
When does it end, did you say?
And when we have our 30 births. So it's not
Okay.
time
Oh,
limited,
okay.
it's space limited.
8 more left.
Huh,
If-
you need
when we
more
have all the
storks
babies.
to curry.
That's how it works.
So the pilot program will hopefully show that it saves money and good for moms
Good for
and
everyone.
baby, or,
Yeah.
you know, pregnant people and babies. And then, because I think requiring everybody to cover doulas would ultimately save us money. Like, it might cost a little
We'll
bit
find
to
out.
get there, but I think we would ultimately save money on it. So I've just been thinking what we did with hearing aids a couple of years ago, where we put it into the
That took
essential
about
benefits.
3 or 4 sessions.
I know it did, but this seems like we could do it faster because we're, you know,
Yeah.
right there.
Something to think about, which it goes into the HRSA stamp grant. The work of the Vermont Department of Health is my greatest hope with that grant, if we're given it by the feds, is that it will create a train the trainers program. So we have, Amy, a big convention, sorry, someone was sitting next to me on another committee, said that they used to work for a DA that does a doula program. I'm most familiar with Washington County Mental Health that does a phenomenal doula project. It's been around for about 9 years. So the concept is they train the trainers. It has great impacts with connections with mental health. There's caseworkers involved. They serve a Medicaid population specifically. And there's a federal grant right now that supports Washington County Mental Health and their doula project. So you could look into that and have their program in. They have an incredible resource.
Cool. Thank you for your enthusiastic
It is
great.
definitely. Definitely.
So is there someone from Washington County Mental Health you would recommend that we hear from?
Maria Rossi.
Okay, well, so we've got Maria Rossi to Kiki. That's good. Thank you.
Thank
Thanks
you.
for your testimony.
Appreciate it.
Appreciate it. So, Ashley, you are here. Welcome. You know, I'm wondering, Ashley, I don't know what your time is. Would it be possible for you to hold off and allow for us to hear from our doula who is here, a doula, executive director for the doula services? Do you have time to stay online until after another witness?
I can stay until 11.
Until 11?
Yes.
Okay, good. So let's do that, and then we'll have a hard stop after about 10 or 15 minutes, and then, or 10 minutes, and then we'll have Ashley testify, and we can always come back. We have some time for discussion within the committee room, so please come up.
Thank you.
And introduce yourself, and thank you, Ashley, for being, patient with us.
Hi, thank you, first of all, for welcoming me to talk about this. Much like Rebecca, this is a passion for me, it's not just a job. And I feel like as much as I want to talk to you, it's really important to me to get across what I want you to hear. So I've written something and I want to read that to you so that I really make sure that you hear what I'm saying and what I want to say. And then I'd like to share a story with you of a client so that you can.
And so two things. One, introduce yourself to the record, but then the second one is hopefully you'll be able to send your testimony.
Yes, absolutely.
Terrific, thank you.
Absolutely. So my name is Lucinda Tarr. I own my own business named Doula Vitae. I've been doing this for 4 years now. I'm located in central Vermont. I work all over Vermont and New Hampshire. So yes, so thank you again. I'm really honored to be here and really excited to share firsthand with you like what we do. And I think Rebecca spoke really well on what we do and the data is amazing. But I want you to hear from me, from a doula, like why this means so much and why it's so important. So, as I said, I'm Lucinda Tarr. I'm a full spectrum doula. I serve families in birth, postpartum, and end of life. And I've been doing this again for 4 years. I first became a doula because of my fascination with birth. As I share with many, the first time I had the honor of supporting birth, I felt like I was exactly where I was always meant to be. Little did I know at the time, the passion I would develop for advocacy, education, and empowerment of others would become my true passion and what I would strive for every woman and their partners to achieve. I tell everyone that I support, my job is to pull back the curtain and prepare you for the journey ahead so that if I couldn't get to you, you would have the confidence to support each other and lead your own way. Women and their families deserve to have the support that helps them use their voices and trust their minds and hearts to make the decisions that are right for them. They learn to ask the right questions, trust their own instincts, and look within them to find a belief in themselves that they didn't know existed until their birth journey begins. The surfacing of this belief is one of the top reasons that women can make wise decisions through their journey, and when reflecting upon it, they feel confident in each and every moment. Our prenatal appointments focus on preparing mentally and physically for the remainder of pregnancy and for labor, birth, and postpartum. I make space for my clients to share their fears, frustrations, and anxieties. Through reassurance that all feelings will be embraced, listened to, and managed if needed, it helps clear the emotions and fears that can often block a woman's mind when they go into labor. I provide a shoulder to lean on, an ear to listen, non-judgmental support, and a brain full of positions, breathing techniques, meditations, and anything and everything else we need to do to make the outcome the best that they hope for. In the hospital or birth center, I use my skills, or I should say at home, I use my skills as needed to help women cope with the sensations of labor, help in keeping the birth partner engaged and cared for, and act as a bridge between providers and clients to be sure that questions are answered and interventions are brought forth only when necessary. I have supported people through all socioeconomic classes. Those who can afford to hire a doula should not be the only class who benefits from the care, support, and education that is provided. I want to help erase the statement, I can't afford a doula. I volunteer my time to those families who cannot afford us, educating, advocating for, and helping them feel worthy of care, regardless of what means they do or do not have. And the story I would like to share with you is one of my most favorite in the last 4 years. I had a mama who was 36, already considered high risk because of her maternal gestation age. So she already faced lots of potential interventions and things that she really did not want. Her hope was to be at a freestanding birth center before, but when she found out she had twins, they obviously could not care for her. Her main goal was to have an advocate, not only through her own voice, but through her team, to make sure that she had all of her hopes and desires met believed in and followed through with. She gave me permission to speak with her providers. So between her conversations with me, my conversations with her providers, we were able to come to that understanding and that middle ground where we could give my client her hopes and dreams for an unmedicated vaginal birth of her twins, which many of you might know is nearly impossible, not because a woman can't do it, but because hospitals are so afraid of giving her that chance. My client, this is amazing, my client carried her twins to 39 weeks, went into labor, birthed her boys, 5+ pound twin boys. Sorry, I get emotional about this. Vaginally, moments apart from each other, with no health complications for mom or babies, and they are thriving. She had a history of postpartum depression before with her firstborn. She had no postpartum depression issues after. That is what we do. And that is just a small scale of what we do. This passion for me needs to hit every woman that it can, because it makes a difference. And if I could have had a doula in my birth journeys, I would have thrived. So I thank you so much for your time. I welcome questions, and I apologize for tears.
Never apologize for your feelings.
And I cry when I see people cry.
I hope this shows you what this means to me and what it could mean to so many women who don't have the availability or affordability to have us by their side.
And I would think that your patient would also have tears while you're telling this story.
Yes, I think so.
There's some tears going around the room. Thank you. Thanks for your testimony.
Thank you.
And so I do have a couple of questions. And one of the things that we've been talking about in here is, so first, you do postpartum, so after birth, you continue to care for your patient. And then one of the things that we've been asking about in here is certification and how you're certified and what organization certifies you and what that involves, not just for initial certification, but then your ongoing practice.
Sure, so there are numerous organizations that you can certify through, and it just basically goes with what your beliefs are. I don't even know how many there are, and for me, I wanted to get into this so quickly that I just kind of picked the first one that came up, and most are either a 4-day certification process where you go somewhere and you go through 4 days of classes, which seems absurd to me because after 4 days, you're supposed to support labor and birth, and especially if you've never done so. So that part is terrifying, but it's very, it is just an all-encompassing kind of, it's 12 hours a day if you're just involved with everything and learning a lot. And then, and every single one there are some that are 8 weeks long that you do online, and the pricing for them varies just depending on who it is. And then it's an ongoing, it's just continuing ed and things like, I have to keep up my certification through, being a member of the organization. So that's just a cost that we have every year, which is minimal, and it's worth it to me to be able to do what I do. And it's the same for postpartum as well. We have it's a separate certification. They do not put them together. But you have to take a course. You have to write and pass tests and stuff like that. So it's kind of like a really short school.
So a follow-up question to that, and then Senator Hardy has a question. So you do have separate postpartum training. Is there would there be a benefit to requiring that postpartum training in addition to the ongoing?
Great question. So I can say that there are some of us that have a passion for birth, and there are some of us that have a passion for postpartum.
Okay.
And so there are some doulas that only cover postpartum. There are some doulas that only cover birth. So I think when you have someone that has to feel like they have to go through the postpartum certification because it's a necessity, but they don't really want to care for families after they have their babes, I think that you would not have to provide the support that they deserve. I think there's something about having passion for what you're doing that makes the family feel so much better. So I don't think requiring the postpartum certification is a necessity. I think in order to prevent the needs of postpartum care is we address the issues in pregnancy and leading up to their labor and birth journey so that we can prevent, because a lot of traumatic births lead to a lot of mental health issues. And if it doesn't get addressed in the postpartum phase because somebody doesn't have a postpartum doula, it can, as we know, lead to a lot more. So I think it can be separate. I think that we focus on birth and make sure that people are ready for that journey and confident about their journey and can look back and be like, hey, look what I did.
Yeah. How old are the twins?
Oh, they were born in June.
Oh, okay.
And their names mean beautiful miracle.
That's awesome. Come on, Senator Hurley, go ahead.
Yeah, thank you. One thing you mentioned that is not in this bill, and I'm not sure that we want to muddy the waters with it, but I'm really interested in it, is you mentioned end-of-life doula, which I know is an even newer concept than birth doulas, but having just gone through the end-of-life with my mother, I could have completely benefited from it. And I'm wondering if that is, I'm not, obviously there aren't the similar statistics with birth and death doulaing, but wondering if you have more information about that, or if you think we should consider that, or that we should put away for another time, or what, but.
I believe in advocacy, no matter what you're going through, and I think that end-of-life doulas help death be as beautiful as birth, because it can be, and it should be for everybody involved. It shouldn't be, we don't talk about it enough. I've talked to numerous principals and heads of schools to say we need to have our children be talking about this so that they don't go through life fearful, and then when there's something traumatic that happens, they're not here, they're more engaged in it. So yeah, I think that eventually people should have the opportunity to have an end-of-life doula as well. But I think they're two very separate issues, because there are plenty of people that don't want to share that end-of-life experience. But everybody wants support in their birth experience, because it's looked at in such different lights that when we talk about birth doulas, there's a light about it. We're bringing life into the world, and that light should be given to people who are transitioning out of life as well, and it can be. But I think in this situation, I think focusing on the bigger issues of helping women who need an advocate so that we prevent any traumatic birth experiences that could lead into mental health issues.
Yeah, absolutely. I completely see the benefits of a birth doula, and I mean, I was fortunate to have the midwife and family support that made my birthing experiences amazing. And I wish I'd had the same end of life.
And I'd love to speak on that, because I think we talk about, and what I was saying is I was talking about partners and birth partners. There are numerous women out there that do not have a partner, that do not have family support, and they're alone. And I went to a hospital the other day and saw women sitting in the waiting room and looking terrified. And if they're that fearful going through their prenatal visits, which are usually only 15 minutes long and their questions are not answered, they should have somebody there. And that's another thing that we do, is I go to these appointments with my clients so that they can feel like they have a voice in those little rooms that they, vitals are taken, and then they're like, hey, do you have any questions for us? And then they're like, okay, see you later. That needs to change.
You just answered my next question, so thank you. That's good.
Yeah, that needs to change. Everybody should have somebody by their side.
Other questions?
Thank you.
Thank you.
Thank you so much.
Don't leave us. I mean, remotely, or if you're here.
I'm
in
hanging
person
out.
all the time. So I'd like to get some testimony from Ashley Berliner. Thank you, Ashley, for waiting. Good morning.
Happy to.
So
Good
you've
morning.
looked
For the
at- And go right ahead.
For the record, I'm Ashley Berliner. I'm the Director of Medicaid Policy for the state of Vermont, and here today to talk about some of the provisions of S109. I cannot provide an administrative position on the bill at this time. We're still working through that process, but I do have several comments to make about specific provisions of the bill, if that's okay with the committee.
Please, go ahead.
So I'll start with the requirement that DVHA maintain a registry of qualified doulas who have met all of the requirements stated within the bill. We, as a payer, maintain a registry of enrolled Medicaid providers and would do so for any doulas that were enrolled in the Medicaid program, but cannot be responsible for a registry for doulas at large across the state. That would be something that the Office of Professional Regulation would most likely be equipped to do, to maintain a list of registries for a professional group that required certain credentials or trainings in order to get on that registry. So I just want to note that we'll maintain a Medicaid enrolled list of doulas if this is something that we cover in the future, but cannot do it for doulas broader than Medicaid enrolled. Any questions about that before I move on?
No, that's pretty clear.
Thank
So,
you.
Yeah.
I suspected that.
Great. On the specifics related to reimbursement on a fee-for-service basis, this is something that we have not seen in other bills. It's highly unusual to see this level of detail for specific sets of services at this level. We wouldn't support having fee-for-service rates in this manner because it doesn't allow us to actually set a methodology or make sure that rates can be updated in the future. We take our rate setting very seriously. We're professionalized. We try to have routine fee schedule updates, and having this kind of wholly outside of any rate setting methodology is just not something that is workable within our business. That said, we have built a fiscal using these rates and the number of live births that we've had over the past couple of years. And depending on the service utilization at these levels, and I did hear earlier that these levels seem inadequate, but at these levels, understanding they might be low, at 100%, so kind of maximum exposure for the Medicaid program, we're talking about $1.8 million gross. So not a huge amount of money at this current rate. At 50%, half of that, so a little over $900,000 gross, 55% of that would be paid by the federal government. In terms of our process for setting rates, we use subject matter experts that we contract with that work at a national level to set rates. They are experts in their field, and so they would be taking information from a variety of sources on what appropriate rates are for doula services and what an appropriate structure would look like. So it would be well informed. We're always interested to know what our commercial payers pay for things, and as well as any other states that pay for these services, along with adjustments for our unique geographics here in Vermont.
Questions? So Ashley, I'm listening to you, and if, rather than establishing a fee within the bill, if we directed the DVHA to set a methodology for payment or reimbursement, would that be more appropriate? Something like that?
Yes. Yes, it would.
Okay. and when Katie is, well, when Ledge Council is available, perhaps we can link you up, and with joint fiscal as well, because I do think we want to continue to look at the bill for markup purposes, so we'll rely on your expertise at that point.
We'd be happy to work with Ledge Council around that.
Terrific.
Thanks, Ashley.
Thank you.
All right, is there anything else? Yeah.
There's one more thing, and
All right.
it's kind of the worst news of this, unfortunately.
Oh,
You've heard me talk before about our Medicaid Management Information System, our MMIS, and how hard it is to program.
Don't do this to us.
I know it's really horrible that this is what we have to deal with. But as you know, we have a 40-year-old legacy claim system that is incredibly cumbersome. So much so, and this sounds like a fiction, but you literally can only have one person coding in it at a time. It is very, very clunky. And given that, I know that the effective date right now is in the past, July 1st, 2023. But an effective date for the future would have to go out longer than I know you would wish in order to accommodate our MMIS. This would require a brand new provider type, which is a significant lift. So we would create a provider type of doula, and that takes approximately a year. So we would be asking for a 1/1/2025 effective date. Sorry, 7/1/2025 effective date.
So calendar year. Oh.
I was gonna say 1/1/25 is not so
Yeah,
bad, but 7/1/25.
I know.
Okay, well, and then, so that is that's a fee for service. Is there any way to plunk this into a blueprint type, all payer model reimbursement, something?
So I think that's something we can take back and think about whether there's anything we can do IT wise that maybe even is a shorter term fix. So our initial conversations have not led us to any great ideas here. I also, if you would be interested, would be happy to come back or have someone else more appropriate come back and just talk about the other things that are in the queue ahead of this, to really understand how we are having to prioritize these things, because again, one person at a time can go in and make these changes. It actually, as a matter of fact, takes 6 months to do this. And so 1/1/2025 could theoretically be possible, but because of the prioritization of projects that are already happening, projects that I know this legislature supports, we would slate it after those already in queue, and that's where we get the 7/1/2025 effective date. So if it would be helpful to kind of go through other projects that are ahead of that to understand, and I know this is bad news. It's very, very frustrating for us that we have to deal with this system, and we're working on a replacement, as you know, but that is what we have right now.
Okay, you heard the sigh within that. Senator Hardy, you have a question.
Thank you, Ashley. Especially, I love to get testimony where I'm like, oh, yep, I expected that, I expected that, I expected that. And all three of these were things I expected. And it's sad you left the worst for last, but it's not unexpected. But I would love to hear what that sort of priority list is, and also get an update of where you are with the system upgrade. I feel like every time you give us this bad news, we're like, wait, but aren't we fixing that? And so having an update, because I know there are things in the works, but I can't remember exactly where you're at with them.
So here's a thought, and that would be helpful to send that list in to Kiki so we can look at it. And then the other question is, well, MMIS continues to haunt us, as it is haunting you. I understand that. But is there some kind of temporary support services? Are there some temporary support services that that MMMIS might be able to use to clear the backlog and to put us in a place where the wait time is only dependent on the time it takes to enter the data. So if we have that information, I know this is a separate issue, but it is something that drives us all crazy in this building, and we hear about it here and we hear about it in appropriations. So if you could send us that information, that would be extremely helpful.
I can. There are people that are much more articulate than I am on that subject, but we'll make sure can get you that information.
Terrific, thank you. And I don't want it to be the major report that takes everybody too much time and detracts from the work that has to be done. But the question about having some temporary support, we'll send a doula in.
Oh,
Yeah.
We could
Okay.
definitely use that here.
It wasn't as bad as you thought, Senator. Ashley, is there anything else that we should know? I hear that you're not giving us a specific recommendation, but we do hear that there may be a path forward, and we will have you connect with our Ledge Council folks on language, and then we'll have to ponder about how to deal with the date issue. Okay, any other questions for Ashley? Yes? We're good? Okay. All right, well, it is just 11. Perfect.
Thank you.
Now, I know that there are folks in the room. I know that there is another doula in the room who is, no, there's no other doula.
If I may.
Yes, please, and for the record, just say your name. And I know that there are folks in the room who would like to make comments. And I'm going to open it up if you'd like to just make a short comment between now and a little after 11, and then we're going to take another break. So,
Amy Johnson, Vermont Care Partners. So I'd love to be able to have either myself or someone from NCSS come in. We have a robust doula program that I started when I was at NCSS, connected to my own
NCSS.
trauma and Northwestern Counseling and Support Services.
Okay, thank you.
Who also, I think there's a component around the Abenaki work, peer-to-peer Abenaki work that I think would be important to highlight, and also speaks to doula supports around perinatal grief and loss. So
I have you on the list, so
Okay.
we'll get you in. Just make sure Kiki has your contact. I know she does. Good. Anyone else? Make a comment. Okay, and if you'd like to testify, or you know of someone who can help us with the questions that we have, either around certification or getting things moving along, because there's an interest in this committee to move this bill along, then please let Keith know.
Is OPR on the list?
Yeah, they are now.
Yeah.
Thanks.
Would
Yes,
it be
ma'am.
helpful to gather certification information and submit that to you?
Yeah,
I'd be happy.
A compilation of patient information would be extremely helpful. It's good background information for us when the
Okay.
bill is presented on the floor by Senator Bueller.
I do know that Maria Rossi, she's already on the list, which is great, because they've done a lot of work around talking about, certification and some of the limitations around that.
Perfect,
specifically around
we need that. We
Yeah, and I
definitely
think
need that.
that talking about core competencies versus certification
Mhm.
and why that matters for access to doulas and the cost.
So we'll get that in testimony, and then that'll help us, put language in the bill that
Yeah.
fits.
Can I ask Lucy one last question
Sure.
before she leaves? Have you ever needed a translator in any of your work, or an interpreter, I should say?
I have not yet, but there are people that I know that I can reach out to if needed.
Terrific. Okay, good. Any other questions, committee? All right, good. I know that, so what we'll do is let's take a 15-minute break. We'll come back at 11:15 and just have a little conversation, in particular with regard to what we heard yesterday and then move on to the next bill.
Thank you.